All right, well, hello everyone and welcome to the SSAT webinar on high yield topics for ABSITE. My name is Connie Shao and I'm a general surgery resident at UAB. I'm just going to share my screen really quickly. So thank you for joining us tonight. If you missed part 1 of our ABSITE series, you can find it on YouTube, our website, or our podcast, SSAT Soundbites. As a general surgery resident, I'm at University of Alabama at Birmingham. My co-moderator is Dr. Fong, who is a surgical oncologist at Mass Gen. Joining us today are 3 residents and fellows who will be speaking on breast and endocrine, HPB and upper GI, and vascular CT. Please feel free to join in the dialogue in the Zoom Q&A section or tweet with us at SSAT News. We have a lot of good journal discussions if you'd like to follow us on Twitter.
Thank you, Dr. Shao. So we're 2 years into the Zoom monopoly now, so I'm sure everyone is well versed with its functionalities. But to briefly go over some best practices, please mute your microphone when you're not speaking. The most important feature I want to bring everyone's attention to is the Q&A feature at the bottom of the screen. We encourage you to use the chat freely by posting your questions in the Q&A because that helps our speakers and moderators focus on the questions and make sure that they get answered and not get drawn out in the chat box. Next slide. So a few days after the webinar, we will be emailing a link to the recording to the participants who register for the webinar. The talk and slides will be posted on our SSAT website in the residence corner, so be sure to check that out. If you need to go back to some of the talks, then quick summaries leading to the exam as well. I also want to put a plug in for our SSAT podcast series. These webinars are all converted to podcast episodes, so if you like to listen to the webinar while driving instead, you can access it on our podcast. Next slide. And finally, for those who aren't members yet, please consider joining the SSAT. I know I'm talking to a crowd who's predominantly in residency, so it'll be the candidate membership. I highly recommend getting involved with the SSAT. We're one of the rare organizations that has abundant opportunities for trainee involvement in multiple different committees, which is an invaluable experience and can lead to more opportunities like academic publications from initiatives, networking with the society's leadership, and eventually leadership positions within the society as well. Next slide. The Journal of GI Surgery is our official journal. Some of our resident and fellow committee members are reviewing for the journal, another opportunity if you're an SSAT member. And be sure to check out our awards website because we have multiple funding applications or opportunities for trainees as well. So I'm going to hand it back to Dr. Shao to get this webinar going.
Thank you, Dr. Fong. And today we have Dr. Quinn, Dr. Chick, and Dr. Starr joining us. So Dr. Ashley Quinn is a resident at East Carolina University and will be speaking on breast and endocrine topics. She is applying for breast fellowship next year. Dr. Connor Chick is a resident finishing his 4th year at the Brooke Army Medical Center in San Antonio and has also spoken on the Behind the Knife podcast on clinical challenges in surgery, HPB, pancreatic head cancer. He is currently in the process of applying for surgical oncology fellowships. Dr. Brett Starr is finishing his cardiovascular fellowship at East Carolina University and will be speaking about vascular and cardiothoracic topics on ABSITE. After fellowship, he will be returning to his hometown to join FryCare Cardiothoracic Surgery in North Carolina. This year, we're doing something a little different and we have poll questions throughout the webinar as well. So please don't be afraid to get involved. As Dr. Fong said, this webinar will also be available on our podcast, SSAT Soundbites, along with our monthly interview podcasts with an author of the manuscript published in JOGS, as well as Mentor of the Month and clinical debates between leaders within their specialty. Now I'll be handing things over to Dr. Quinn, who will be speaking on breast and endocrine topics on ABSITE.
All right, thank you so much. Let me go ahead and share my screen. All righty. So with that, we'll get started. So breast and endocrine, both of them are worth about 4% on ABSITE. They're really important topics. There's a lot to cover in a short amount of time. So we'll go ahead and get started. We'll start off with endocrine. So our first question here is a 32-year-old woman has a 0.8 centimeter asymptomatic left-sided nodule seen on CT after she came in from a fall on her ladder. She undergoes FNA of this lesion and it shows a follicular neoplasm. So what is your next step? And I know with the polling, it will take some, it'll show us the answers at the end, but if you can, go ahead and try to answer it. All right. So we'll go ahead and go to the answer, which is a thyroid lobectomy. So with this, really kind of the key here is that it's a follicular neoplasm, and you can't differentiate that with a benign or a malignant neoplasm. So you have to do a lobectomy in order to evaluate the tumor extension and see if you have any invasion from the capsule or any vascular invasion, and you need to do a lobectomy in order to do that. A cord needle biopsy is not going to be sufficient. So the same is going to be true for your Hürthle cell. So just a couple quick points. So as far as anatomy goes, a thyroglossal duct cyst will often present, and kind of a key distinguishing feature here is going to be a midline neck mass that will move upwards with swallowing. And you need to resect these because there's a risk of infection and future malignant transformation. Blood supply to the thyroid is going to be your superior and inferior thyroid arteries. Superior thyroid artery comes off your external carotid, and it's going to be the first branch off that artery. Your inferior thyroid comes off the thyrocervical trunk. And that artery also supplies all of your parathyroids. Two major nerves that you want to keep in mind when doing a thyroidectomy are your superior laryngeal nerve, and this provides the motor to the cricothyroid muscle, specifically the external branch of your superior laryngeal nerve. And if you were to injure this, you would have loss of projection and voice fatigue. Your recurrent laryngeal nerves is going to supply motor to everything else. You can have hoarseness with a unilateral injury, and if you have bilateral injury, you can have airway compromise that might necessitate a tracheostomy. One quick point about the recurrent laryngeal nerve. So their course is going to be different on each side. So the left will loop around the aorta and the right will loop around the right subclavian artery. And sometimes they like to ask about that. So if you have a patient who presents with a asymptomatic thyroid nodule, one of your first steps is going to be an ultrasound, and you can kind of view this as an extension of your physical exam. So with your ultrasound, you are going to have your TRIRAD, classifications. And so this will help you determine if you need to perform an FNA. And so things that you look for that would make you think you have a benign lesion are cystic spongiform, if it's wider than it is tall, if you have smooth margins, and if it's anechoic. Things that would make you think more malignancy is being taller than it is wide, irregular borders, and if you have a solid nodule. So let's say you get an FNA, your Bethesda category will then help you determine what your next step in management is. So you can have a benign lesion where you don't need to repeat anything or take any further steps. You can have a follicular neoplasm like we did in our question, where you have to perform a lobectomy to determine if it's malignant or not. And if it's suspicious for malignancy, then you can go on to do a lobectomy or a total thyroidectomy. And one thing I'll point out about imaging is if you see microcalcifications, that's going to make you very suspicious for malignancy. There's like an 86 to 95% relation to malignancy if you see microcalcifications on there. So quickly, the different types of thyroid cancer. So papillary is going to be your most common and least aggressive. This is going to be, it's going to demonstrate lymphatic spread. You'll have sonoma bodies and orphan antinuclei on your path. Follicular is hematogenous spread, not lymphatic. And with these, you can start with a lobectomy. You might have to do a total thyroidectomy if you have a large tumor, any evidence of extrathyroidal disease, if it's bilateral lesions, if they've had previous radiation therapy. And with these, you want to kind of make a note that if you were to do a total thyroidectomy for your papillary cancer, you're going to be able to use your thyroglobulin post-op to monitor for recurrence. And it will also make the radioactive iodine more effective. For medullary thyroid cancer, this is going to be associated with your MEN2A and 2B. You might see amyloid deposition on path, and you need to do a total thyroidectomy with a central neck node dissection. If you have any evidence of lymphatic spread, you might have to do a modified radical neck dissection. And with anaplastic thyroid cancer, you are not really going to likely have to do a total thyroidectomy because these patients will often present late because this is such an aggressive cancer. They might need palliative radiation or trach for compressive symptoms. And kind of what I mentioned earlier about the Hürthle cell, it's a lot like the follicular thyroid cancer where you have to do a lobectomy to see if it's malignant. And if it is, then you would do a total thyroidectomy. So our next question. All right, so we have a 36-year-old woman who comes in with asymptomatic primary hyperparathyroidism. For indication for a parathyroidectomy is going to be her age, and we'll go over all of the indications in a minute. So quickly, embryology, your superior parathyroids come from your fourth pharyngeal pouch, your inferior from the third. And what's important to know about your inferior parathyroids is that these are more likely to be ectopic. And the most common ectopic site is going to be the thymus. And this is different than the most common missing site. So if you have a patient who underwent a previous parathyroidectomy or attempted parathyroidectomy and the parathyroid was not able to be found, the most common missing or most common site for a missing parathyroid is going to be the normal anatomical position. But most common ectopic site is the thymus. Blood supply, we said it already, inferior thyroid artery. So parathyroid hormone increases serum calcium. It does this by increasing renal calcium absorption, increasing osteoclast activity, and then increasing vitamin D production, which goes on to increase intestinal calcium absorption. Calcitonin is the opposite. So it'll decrease your serum calcium, and it does this by inhibiting osteoclast. And I always remember calcitonin keeps calcium in the bones. And it'll also increase your urine calcium excretion. So primary hyperparathyroidism can be caused by your single adenomas, multiple adenomas, diffuse hyperplasia. If you have an adenoma, you can resect the adenoma or adenomas. If you have diffuse hyperplasia, you're going to do a subtotal with 3.5 gland parathyroidectomy or total thyroidectomy or parathyroidectomy with an autoimplantation. And you're going to do the autoimplantation into the forearm or the sternocleidomastoid mastoid muscle. Intra-op, you want to see a greater than 50% drop in your PTH levels from your preoperative level to 10 minutes after resection. If you don't see that drop, you can wait another 10 minutes for a total of 20 minutes. And if it's still high, then you need to go searching for the remaining abnormal gland. So let's say that you've gone through and you've tried to find it and you can't. So you can then close and follow the patient's PTH. If it's still elevated, you can get a Sestami V scan to try to localize the adenoma and before you reoperate. Other causes, so secondary hyperparathyroidism, this is going to be in your renal renal failure patients, and this is with dialysis causing calcium loss. You're going to treat this mostly medically with calcium vitamin D supplements and phosphobinders. Surgery is only done if medical treatment fails. Tertiary is going to be seen in your renal transplant patients, and they are going to get a subtotal or total parathyroidectomy with autoimplantation. And quickly, other causes of hypercalcemia. So you're going to want to differentiate between familial hypercalcemia, hypocalciuria, and the primary hyperparathyroidism. And with these patients, it kind of says it in the name, their serum calcium is going to be high and their urine calcium is going to be low, compared to hyperparathyroidism, where their urine calcium will be high. For the FHH patients, you're not going to do anything. You don't do surgery for them. Other causes of hypercalcemia, a big one is going to be malignancy, and this is through two mechanisms. The most common being that the cancer is going to create a parathyroid hormone related peptide, and then you can also have it with lytic bone lesions. If a patient presents and they have an extremely high calcium level, you want to keep parathyroid cancer in mind. It's very rare, but treatment for it's going to be year-wide en blanc excision. Gave it away, but we have a 62-year-old woman with a history of lung cancer about 3 years ago, who presents with unintentional weight loss, vague abdominal pain, and has a 3.2 centimeter heterogeneous tumor in her left adrenal gland. So what is your most appropriate next step? And I kind of gave that one away, so we will. Go ahead and go. So plasma catecholamines and metanephrines. So this patient has a history of lung cancer, and has very concerning symptoms of unintentional weight loss, and you're going to be concerned that this is a MET. Before you go do a biopsy or an adrenalectomy, you need to rule out a Pheo. So even though you're pretty certain this is a MET, you still need to do that before moving on. All right, so adrenal real quick. Left adrenal vein drains into the left renal vein, and the right adrenal vein drains directly into the IVC. When you have a patient presenting with an indental lymphanoma, you want to first make sure to see if it's a functioning tumor or not. And you're going to order a whole list of tests, and here the urine metanephrines, the BMA, catecholamines, urine hydroxycorticosteroids, serum potassium, plasma renin, and aldosterone. Once you've determined if it's functioning or not, you need to decide if you need to do surgery. And you do surgery if it's functional. You do surgery if you have images that are suggestive of it being malignant, if it's greater than 4 to 6 centimeters, or if it's enlarging over time. So if a patient had a CT about a year ago and they have a repeat one now, then, and it's showing an interval enlargement, that's something that you would want to take to surgery. Briefly, common metastasis to the adrenal gland, lung is number 1, breast, melanoma, and renal. When you are doing your adrenalectomy, if you are suspicious at all for cancer, it's preferential to do an open adrenalectomy to reduce the risk of tumor rupture or spillage into the abdomen. And if that were to happen, you can treat that with Midotane. So we have our next question here. So 29-year-old man presents the ED with a severe headache. When he arrives, his pressure is 205/125. He's given metoprolol for his hypertension and goes into cardiac failure. He's later found to have a left adrenal mass, which is confirmed to be a pheochromocytoma. What is the most likely explanation for this cardiac failure? All right, so administration of a beta blocker before an alpha blocker. So with patients that have pheochromocytoma, you want to do an alpha blocker before your beta blocker to prevent cardiac failure from happening. So quickly, the adrenal medulla is ectoderm, neurocrest cells. Its job is to produce catecholamines, pheochromocytoma. Diagnosis is going to be a screening test of a plasma metanephrine. So this should be your initial screening test. It has a higher false positive rate. It can be altered by things like Tylenol or decongestants. So if you have a patient who has a positive screening test, you want to confirm that with a 24-hour urine metanephrines test. If you have a biochemical diagnosis but trouble localizing with CT or MRI, you can do an MIBG scan to help with localization of that Pheo. Pre-op prep is very important for this. So you want to have volume replacement. You want to do the alpha blockade first with phenoxybenzamine or brazosine, and then you can do your beta blockade if the patient is tachycardic or has arrhythmias. During your adrenalectomy, you want to ligate the adrenal vein first to avoid spilling those catecholamines during tumor manipulation. And then our next question. So 27-year-old female presents with abdominal pain and is diagnosed with kidney stones. She's found to have an elevated calcium and PTH. and she has a parathyroid mass found in her ultrasound of the neck. Her only other complaint is that she has bilateral milky discharge from both nipples. She is not pregnant or breastfeeding. She's adopted, so she doesn't know her family history. Which of the following should be evaluated for additional tumors? All right, so it's going to be the pancreas. So anytime you have a patient where truthfully, if it says that they're adopted, you're going to your brain's going to go to genetic syndromes, and these are a favorite on ABSITE. So your MEN syndromes, just quickly, I remembered from med school this like mnemonic PPP for MEN1, and then as it goes down, more M's come in. So MEN1 is going to be your parathyroid hyperplasia, your pancreatic islet cell tumors, most commonly a gastronoma, pituitary adenomas, with most common being a prolactinoma. MEN2A and 2B are with the rat proto-oncogene, and this is MEN2A is going to be parathyroid hyperplasia, a pheochromocytoma, medullary thyroid cancer. MEN2B is a pheo, medullary thyroid cancer, and mucosal neuromas, marfanoid habitus, and musculoskeletal abnormalities. And most questions that I've seen, it's like what we saw where it'll give you 2 of them, and then it wants you to know what the third part of that syndrome is. Because we're kind of short on time, just some extra things. Graves' disease, you want to know that it's a TSH receptor antibody. And with Hashimoto's, it's a thyroid peroxidase antibody. And we'll kind of go on to breast now. So we have this patient here, a 20-year-old woman with a known history of BRCA1 mutation, presents to you for surveillance options. She's not interested in prophylactic surgery. So what surveillance is most appropriate for this woman? And it's going to be an annual MRI starting at age 25. So we'll kind of go into screening guidelines. So NCCN guidelines recommend an annual mammogram starting at age 40 for average risk women. For high risk women, usually they'll recommend an annual MRI as a supplemental screening. And high risk would be anybody who has a 20% or greater lifetime risk of breast cancer, those with BRCA mutations or other genetic diseases like Cowden disease, and then a first-degree relative with one of those, and a history of chest radiation between the ages of 10 and 30. And then specifically for BRCA mutations, so you're going to have a high lifetime risk of breast cancer, as well as ovarian cancer, and specifically BRCA2 is associated with male breast cancer, prostate, and pancreatic cancer. Guidelines for breast specifically for BRCA mutations is going to be a clinical breast exam starting at age 25. And this will be every 6 to 12 months, I would say annual. And then annual screening with an MRI for ages 25 to 29. And then once she reaches 30, would be an annual mammogram, plus minus MRI as a supplemental imaging. All right. So a 63-year-old woman is found to have BIRADS4 lesion on breast diagnostic mammogram. No correlated lesion is seen on ultrasound. She undergoes a core needle biopsy that shows fibrocystic breast disease. What is your next best step? So that's going to be an excisional biopsy. All right, so we'll go into the indications for an excisional biopsy in a couple slides, but this specifically is due to discordant path. So with diagnostic breast imaging, if you have an abnormal screening mammogram, your next step is to get a diagnostic mammogram with or without an ultrasound. If a patient presents with a breast mass, you want to evaluate this with diagnostic imaging. If she is less than 30, Then you start with an ultrasound. If you're suspicious for malignancy, you can add a mammogram. Patients that are 30 and above, you want to do bilateral mammogram and ultrasound. And in pregnant or breastfeeding women, it'll be an ultrasound as first line. Your BI-RADS classifications, this is very high yield. It's just something you have to memorize, unfortunately, but your BI-RADS 0 is gonna say that you need additional imaging, it's incomplete. 1 and 2 are benign findings or negative, and you need routine screening. Probably benign is BI-RADS 3, and that's the short-term interval repeat mammogram. Suspicious for malignancy, you're going to go and do a core needle biopsy. So indications for an excisional biopsy. Oftentimes on questions, I see the discordant path. So a patient presents and you have very suspicious imaging, but when their core needle biopsy comes back, it's benign tissue. So you need to go in and make sure that you are adequately sampling what you see on imaging. So other reasons for excisional biopsy are an undefined fibroepithelial lesion. So you can't distinguish if it's a phylloides tumor versus a fibroadenoma just on core needle. So you have to go in and do an excisional biopsy. This is a lot like the follicular neoplasm we talked about in thyroid. Risk lesion, so anything with the word atypia in it is going to need an excisional biopsy. And then LCIS will also need an excisional biopsy. So if you see LCIS on your core needle, get the excisional biopsy. A common question is that once you get the excisional biopsy, it's just LCIS, but there's a positive margin. Do you need to go back and do a re-excision? No. For LCIS, you do not need to go back and do a re-excision to get negative margins. The only exception might be pleomorphic LCIS, which behaves a lot like DCIS. And then you would have to go back and get those negative margins. But in general, for LCIS, you do not. Phylloides tumors, so these have epithelial and stromal components. Treatment for these is going to be wide local excision with a 1 centimeter gross margin. If you have positive margin, you need to go back and re-excise. These spread hematogenously. I think of them as acting like sarcomas. With these, you do not need to do a sentinel lymph node biopsy. And we have our next question, which is a 60-year-old woman presents following a core needle biopsy showing ER-positive DCIS with no areas concerned for microinvasion. What is the most effective treatment option for this patient? So it will be your wire localized segmental mastectomy with post-op radiation and consideration for tamoxifen. And I've noticed with breast questions that you kind of have to read every single word with the answer choices sometimes. So this can be referred to as a segmental mastectomy or a partial mastectomy or a lumpectomy. So you really want to make sure that when you're looking at your answer choices, you are paying close attention to the phrasing. So with DCIS, this is, disease that's confined to the basement membrane, but it can harbor invasive disease. So you need to do an excisional biopsy and, excisional excision. So you need to have at least 2 millimeter margins with DCIS, which is in contrast to invasive disease where you just need no ink on tumor. Your treatment options for DCIS are going to be a lumpectomy with radiation for most cases. And then if you elect to do a mastectomy, you need to include the sentinel lymph node biopsy with that, because if you do the mastectomy and then you find out that there is invasive cancer, in order to do axillary evaluation, you have already burned that bridge because of the disruption of the lymphovascular channels. So at the time of the mastectomy, you do the sentinel lymph node biopsy in case there is invasive disease present. And then for ER/PR positive, you can give adjuvant endocrine therapy for risk reduction. And then we have a question. Instead of, would it be So, yeah, so if she had already hit menopause, then you would do an aromatase inhibitor instead of tamoxifen. So specifically if a patient, it states that the patient's premenopausal versus postmenopausal. If it's premenopausal, it's tamoxifen. If it's postmenopausal, it would be an aromatase inhibitor. All right, so treatment for early stage breast cancer. So again, you have your mastectomy with a sentinel lymph node biopsy, and then you have breast conservation therapy with a lumpectomy, a sentinel lymph node biopsy, and post-op radiation. And again, you want no ink on tumor. If you have a positive margin, you re-excise it. The Z11 trial is very important. So this states that if you have less than 3 lymph nodes with disease, then you do not need to perform a full axe dissection if post-op radiation is being performed. And so contraindications to breast conservation therapy are going to be patients who can't receive radiation. And that's if they've already had prior chest radiation, if they have a connective tissue disease, specifically scleroderma, and if it's too early in pregnancy to time it to where they get post-op radiation after delivery. If a patient has diffuse multicentric disease, so multicentric disease is disease that is present within more than one quadrant of the breast. And this is in comparison to multifocal disease, which is multiple areas of disease in one quadrant. Tumors that are greater than 5 centimeters, and then a high tumor to breast ratio. So if you were to excise the tumor only, it would leave a very poor cosmetic outcome. All right. So chemotherapy, so indications for chemotherapy, any patient with metastatic disease, positive nodes, triple negative breast cancers, high-grade tumors, or tumors that are larger than 2 centimeters, HER2 positive tumors. So generally you'll give the systemic chemo and the anti-HER2 agents. And then if a patient has ER positive, HER2 negative, and node negative, if they have a high oncotype score. And sometimes they'll just say high oncotype, but it's 26 or greater. As far as neoadjuvant versus adjuvant, the big thing with neoadjuvant therapy is that it increases your chances for breast conservation therapy. So if you have a patient who comes in with a large mass, and if they have palpable nodes at that time and they undergo neoadjuvant therapy and have a great response and they no longer have palpable nodes, then and it shrinks the tumor, you can do a lumpectomy, and then you can do a sentinel lymph node biopsy. So if they no longer have palpable nodes after neoadjuvant therapy. This is in contrast with inflammatory breast cancer, where even if they have a great response, you still have to do the axillary lymph node dissection because the cancer will cause the sentinel lymph node biopsy to be unreliable because of the lymphovascular invasion. Radiation, so it's for local regional control. It will follow the lumpectomy and breast conservation therapy. Important to note, it can be omitted in women older than 70 with ER positive T1 and 0 cancers if they take endocrine therapy. Indications for post-mastectomy radiation are large tumors greater than 5 centimeters if you have positive margins that cannot be re-excised. If you have 4 or more positive lymph nodes, you can consider it for 1 to 3, and then inflammatory breast cancer. Endocrine therapy, so this is going to be for your hormone positive disease. We kind of mentioned it already, but premenopausal tamoxifen, postmenopausal is aromatase inhibitors, and these are given for at least 5 years. They will sometimes like to test on the side effects of these. So with tamoxifen, you can have increased risk of DVT-PE. For anti-HER2 therapy, trastuzumab will be cardiac toxicity and cardiac failure. We have this question here. 47-year-old woman presents with redness, swelling left breast, peau d'orange. Changes are also noted. She was previously given antibiotics, but there wasn't a change in this, and she undergoes diagnostic mammogram. An ultrasound has a mass in the upper outer quadrant. Biopsy shows invasive ductal carcinoma. She doesn't have palpable nodes. Staging workup is negative for metastatic disease. What is her best option after completion of neoadjuvant chemo? And for time, we'll just kind of go, but it's a modified radical mastectomy. So with inflammatory breast cancer, it's a clinical diagnosis. You're going to look for the erythema, edema, and the pot-orange changes. And a lot of the time, they might mention the patient had tried like antibiotics, that didn't work. And this is going to make you very suspicious for an inflammatory breast cancer. Skin punch biopsy can be done, and it'll show this like pathognomonic dermal lymphatic invasion, but skin punch biopsy is not required for diagnosis. And just note that, remember, inflammatory breast cancer is T4, not necessarily stage 4. Stage 4 would have metastasis. And the treatment is going to be the same every time. It's going to be your neoadjuvant chemo, your modified radical mastectomy, and post-op radiation, plus minus endocrine therapy, depending on hormone status. And so your modified radical mastectomy is going to be your total mastectomy with your axillary lymph node dissection of the levels 1 and 2. And just a quick note, this is different than for melanoma axe dissection, where you do levels 1, 2, and 3. So with breast, it's just levels 1 and 2. All right, and then our last question. 56-year-old woman is referred to you by her PCP for excoriation of her left nipple that's been present for several months despite using topical treatment. There are no abnormalities in her breast exam that are palpable. She undergoes biopsy that confirms the diagnosis and would like to know the next best step in her care. So it's going to be her, it's going to be bilateral mammogram and ultrasound, and this is because she has Paget's disease. There's numerous questions on SCORE about this. Seems like ABSITE and SCORE both really like this topic, so it's just something to keep in the back of your mind when you have someone who comes in with eczematous changes of the nipple. You think Paget's, and Paget's is going to be very strongly associated with an underlying DCIS or invasive cancer, so you need to work them up for that, and you start by doing a bilateral mammogram and ultrasound. You can do a full thickness biopsy of the nipple areolar complex to assess for Paget's, and you'll see large cells with pale cytoplasm and prominent nucleoli. The treatment, it depends on if they have another mass that is not near the nipple. So if it's multifocal, meaning it's just your Paget's disease on the nipple and the mass can be behind the nipple, you could do a central partial mastectomy, sentinel lymph node biopsy, and post-op breast radiation, or a mastectomy with sentinel lymph node biopsy. If you have multicentric disease, so you have Paget's in the nipple, but you have a mass in the upper outer quadrant, then you would need to do a total mastectomy with sentinel lymph node biopsy. So another question, if we do breast conservation therapy, are we supposed to do a sentinel lymph node biopsy? So if it's for an invasive cancer, yes. If it's for DCIS, no, because with DCIS, it's the understanding that it's confined to the basement membrane. So you do not need to do a sentinel lymph node biopsy for DCIS if you do breast cancer, if you just do the lumpectomy. If you do the total mastectomy for DCIS, then you would have to do the sentinel lymph node biopsy for that, because you don't want to have already had the disruption of the lymphovascular channels if you find out that there is a cancer on that specimen post-op. Did that answer your question? Okay. So very quickly, male breast cancer, also a common topic associated with BRCA2 and Klinefelters. Here, mastectomy is going to be the major treatment. Chemo if their tumors are greater than 0.5 centimeter. And then if they are hormone receptor positive, then tamoxifen is the preferred agent. And with pregnancy-associated breast cancer, radiation is contraindicated, so it requires a mastectomy. And the exception is if they are in their 3rd trimester, and you can do the lumpectomy and then time the radiation for after delivery. And then when you're doing their sentinel lymph node biopsy, you do not give the blue dye, that's contraindicated. You would give the radioactive tracer, the technetium-99. And chemotherapy is contraindicated in the 1st trimester and also the last couple weeks before delivery. And then there are some other slides on here, but I believe that's my time. So.
All right, thank you so much, Dr. Quinn, and keep asking questions in the Q&A section if you have any more questions, and otherwise we will move on to Dr. Chick.
I'll get started sharing my screen. All right, so we'll jump right in with hepatobiliary and upper GI cancers. So question number one, a 60-year-old man presents with 5 days of unrelenting right upper quadrant abdominal pain. Physical exam shows normal vital signs, obesity, and right upper quadrant tenderness. The white count is 15,000. Total bilirubin is 2.0 and direct is 1.5. Ultrasound demonstrates a thickened gallbladder wall, pericholecystic fluid, and intrahepatic biliary dilatation. The common bile duct is 6 millimeters in diameter. What is the most likely diagnosis? So it's going to be Moritz syndrome. So just to review some benign biliary topics, of course, these are things that we're all very familiar with and deal with on a daily basis, but because of that, it is commonly tested. Things that would be important to know in terms of answering questions on benign biliary would be, what are the elements of a complete intraoperative cholangiogram? So that would include filling of the duodenum, no filling defects in the common bile duct, and filling of both hepatic radicals. So you need to have all three of those in order to have, they're called a negative IOC. Something else that comes up is cholecystectomy in pregnancy. It used to be that it was recommended that only you would only operate in the second trimester, and otherwise would try to get through the pregnancy with non-operative management. However, guidelines on that have recently changed to state that laparoscopic cholecystectomy is safe during any trimester of pregnancy, but there are still theoretical concerns about fetal loss with operating in the first trimester and induction of labor for operating in the third trimester. Gallstone pancreatitis or biliary pancreatitis comes up often. This is one of the two most common causes of acute pancreatitis in the US. In general, the sequence of treatment is not mandatory, whether a patient, if they were to need endoscopic decompression, gets that first as opposed to cholecystectomy with IOC. However, it is mandatory to do something to clear the duct prior to discharge. And so you can do just a cholecystectomy with IOC, but they should have that prior to discharge. And the other point that comes up with gallstone pancreatitis is that the patient should have a cholecystectomy during the index admission. Gallstone ileus, of course, is sort of a misnomer, not really an ileus, but really a bowel obstruction, where you have a cholecystoenteric fistula, most often to the duodenum, where you can get erosion of a very large gallstone that travels all the way down the small bowel and typically will get stuck right at the ileocecal valve, causing an intraluminal obstruction. The treatment for this is making an enterotomy proximal to the stone and removing the stone, and then at some point dealing with the gallbladder and the fistula. The timing of that is somewhat controversial, and so very unlikely to force you into answering that question on the test. And finally, Moritz syndrome, not common, but definitely scary. So this occurs when there is extrinsic compression or even fistulization of a very large gallstone within the gallbladder that causes, again, compression or obstruction of the common bile duct. So just to review some of the types of Moritz syndrome, the type we think of most commonly is type 1, which is external compression of the common hepatic duct by this large stone. However, you also can have a cholecystocholedochal fistula, where that stone starts to erode into the common bile duct. And those different types are shown here. I think knowing these specific types is probably not all that high yield, but just being aware that Morency syndrome tends to have a presentation that looks somewhat like choledocholithiasis, but the key is having a normal caliber distal common bile duct, while also having other findings consistent with bile duct obstruction. So move on to question number 2. This is a 42-year-old woman who presents 4 days after a laparoscopic cholecystectomy for chronic cholecystitis. She's febrile to 102, tachycardic to heart rate of 116. Her blood pressure is 96/62. Her white count is 12,000. Her total bilirubin is 4.2, and her direct bilirubin is 3.4. On ultrasound, she has a fluid collection in the gallbladder fossa and has intrahepatic ductal dilatation. On admission, she is resuscitated, has normalization of her vital signs, and her fever resolves after initiation of broad spectrum antibiotics. What is the next best step in management? So our options are primary repair of a common bile duct injury, choledochojejunostomy, resection of the bile duct with hepatic OJ, PTC and external drainage, or percutaneous drainage of a biloma only. So our best answer here is going to be a PTC with external drainage. Bile duct injury is definitely something that's commonly tested. Things to know would be the elements of the critical view of safety. So 2 and only 2 structures entering the gallbladder after having cleared the cystic plate of all fibrous and fatty tissue, and a third of the gallbladder elevated off the liver. That third point is the one that I think people tend to miss, is the mobilizing a third of the gallbladder off the liver. Intraoperative cholangiogram is the most sensitive way to diagnose bile duct injuries intraoperatively. Again, there is controversy about whether IOC should be done routinely as opposed to selectively, and there's data to support both points. So unlikely to be a test question. However, it has been shown that it's the most sensitive way to diagnose a bile duct injury if you're suspicious for an injury. The mechanism for these injuries can be either direct clipping or division of the duct. These can cause early obstruction or bile leak. The other common mechanism is a thermal injury, which tends to present as a delayed bile duct stricture. If the injury is recognized immediately, the best next step is going to be immediate repair by an experienced surgeon. So in general, if you're at a tertiary center and there is a hepatobiliary surgeon available, then intraoperative consultation would be the answer. If you are not experienced in doing a bile duct injury repair, then transfer to a tertiary center might be the best next step. In the case of a delayed recognition of a leak, such as in the question, the best approach in general is going to be non-operative management initially, followed by delayed repair or reconstruction. Just to review the classification for these bile duct injuries. So on the left, we have the Strasbourg classification. These specific classifications are not likely to be tested, but just good to be aware of where these injuries can occur. They can occur due to a leak directly from the cystic duct, or injury to an aberrant right hepatic duct. And of course, the one we worry about the most is injury directly to the common bile duct, or even to the confluence or higher. Question number 3, an otherwise healthy 56-year-old man presents with painless jaundice. He has dilated intrahepatic ducts on CT. He has an MRCP that shows a tumor at the confluence of the right and left hepatic ducts extending into the right hepatic duct, but not involving the left. There is no evidence of portal hypertension or decreased arterial inflow to the liver. The calculated functional liver remnant is 15%. What is the next best step in management? So options here are extended right hepatectomy, a standard right hepatectomy, right portal vein embolization, neoadjuvant chemotherapy, or palliative biliary stent. So the best answer here is right portal vein embolization. There's a couple steps in this question to get through. So first is recognizing that this is a potentially resectable, hilar likely cholangiocarcinoma. The surgical treatment for this patient is most likely going to be a right hepatectomy or maybe even an extended right, but the functional liver remnant in this patient is not high enough to support upfront liver resection. So one of the options for this patient would be portal vein embolization in order to get hypertrophy of the side that is going to remain. And so the key point is you want to embolize the diseased side in order to induce hypertrophy of the contralateral side. So to review cholangiocarcinoma in general, there's not a whole lot of specific risk factors, but smoking is definitely one. And then there are some biliary tract infections that can predispose to this, as well as inflammatory diseases of the bile duct, such as primary sclerosing cholangitis. Treatment for cholangiocarcinoma depends on the location. So if it's distal near the ampulla, the treatment is going to be a Whipple. If the tumor is confined to the mid portion of the bile duct, which is relatively rare, the treatment there can be bile duct resection alone with hepatocogenostomy. And then for hilar cholangiocarcinomas, the treatment is going to be bile duct resection plus or minus a hepatectomy, depending on the involvement of the hepatic ducts in terms of which side and to what extent. If the cholangiocarcinoma is intrahepatic only, then hepatectomy, if the tumor is resectable, would be the most appropriate surgical therapy. Just to review the different types, again, not so much to memorize which type is which, but just to recognize there are different locations for hilar cholangiocarcinomas. So type 1 is with tumor below the confluence. Type 2 involves the confluence, but neither the right nor left duct itself. Type 3 involves either the right or left hepatic duct. And then type 4 will involve either both hepatic ducts or multicentric tumors. The key point here is that type 4, generally speaking, is not resectable up front. Other key points with biliary tract cancers, things to think about. So colorectal cysts, multiple types of these, and the type is going to determine the treatment. And I have an image on the next slide. So let's look at that first. So our normal configuration there, type 1 is going to be fusiform dilation of the common bile duct, and commonly can be the essentially entire course of the common bile duct. Type 2 is going to be a saccular type cyst off the common duct. Type 3 is sort of like a diverticulum at the ampulla. Type 4 is going to involve both the common duct and intrahepatic duct. And then type 5, otherwise known as Caroli's disease, is completely intrahepatic. And so again, to review, again, to review the treatment for these different types of colorectal cysts. For type 1, it's going to be resection of the bile duct with hepatic-OJ. Type 2 is resection alone or with hepatic-OJ. So with a saccular colorectal cyst, you could just resect the cyst if that's feasible. For type 3, options include endoscopic sphincterotomy to decompress that the cyst versus open excision and sphincteroplasty. Type 4 would be resection with hepatic-OJ plus or minus liver resection of the involved segment or lobe. And then type 5 actually requires a transplant for complete treatment. Gallbladder cancer, in terms of things to know for the ABSITE, the most important really is the extent of surgical resection that's mandatory. So for a TIS or a tumor, an in situ tumor, or for T1A, which involves only the lamina propria, cholecystectomy is sufficient. And so the way this might show up in a question would be that you do a cholecystectomy for acute cholecystitis, and on pathology, you find out that there is a malignancy within the specimen, but it's confined to the lamina propria. That patient would be surgically complete. If it invades any deeper, that requires a liver resection. So that would be segment 4B and 5. That's essentially the margin of liver that abuts the gallbladder. Moving on to question number 4. A 48-year-old woman presents following hospitalization for decompensated cirrhosis. Which of the following would be an indication for a transjugular intrahepatic portosystemic shunt, or a TIPS? So options are new onset ascites, refractory encephalopathy, recurrent variceal bleeding, splenomegaly, or referral for transplant. The best answer here is recurrent variceal bleeding. Cirrhosis and portal hypertension is another commonly tested topic. In terms of etiologies of portal hypertension, we can divide them into prehepatic, intrahepatic, and posthepatic. Prehepatic is relatively uncommon. It involves or includes portal or splenic vein thrombosis as one of the more common etiologies. Intrahepatic etiologies can be divided into pre-sinusoidal, sinusoidal, and post-sinusoidal, with sinusoidal being by far the most common of those. And that would include cirrhosis, amyloidosis, and nodular regenerative hyperplasia. Posthepatic causes of portal hypertension would include Budd-Chiari syndrome, which is a hepatic vein thrombosis, and right heart failure, otherwise known as cardiac cirrhosis. In terms of evaluation for ascites, they may ask about whether the ascites is due to portal hypertension or not. Another cause might be malignancy. The important lab finding to look for is the serum ascites albumin gradient, and a gradient over 1.1 is consistent with portal hypertensive ascites. So the way to calculate this gradient is you just subtract the serum minus the ascites albumin values, and if that value is over 1.1, that's consistent with portal hypertension. For bleeding varices, in terms of the acute treatment, so this is typically going to involve endoscopy, sometimes octreotide drips, and in the unstable patient may involve something like a Blakemore balloon, as opposed to prevention, which typically is going to involve beta blockade and a treatment of the underlying cause. Ascites we sort of talked about already. Encephalopathy is due to the inability to metabolize organic acids by the liver, and other substances, of course, such as ammonia, which may or may not correlate with the clinical degree of encephalopathy, that's very patient dependent. In terms of indications for TIPS, so these ones listed here are the more common ones. So recurrent varices, recurrent bleeding varices rather, refractory ascites, but it's important to be cautious in patients who are encephalopathic, as TIPS will reliably worsen encephalopathy. Hepatorenal, just other entities to be aware of, hepatorenal syndrome and hepatopulmonary syndrome are direct consequences of cirrhosis and portal hypertension, and these should push you towards transplant. Just to review what a TIPS actually is. So in general, the interventional radiologist will access the internal jugular vein and will create a conduit between a hepatic vein and an intrahepatic portal vein. Moving on to question number 5, a 38-year-old female is found to have a 3-centimeter pancreatic cyst in the tail on a CT chest, abdomen, pelvis done for a motor vehicle collision. The cyst has peripheral calcifications, an EUS is done, and no mural nodule is seen. Some fluid is aspirated from the cyst, and the CEA is 1,000. What is the most likely diagnosis? So our options are a main duct IPMN, a branch duct IPMN, mucinous cystic neoplasm, serous cystic neoplasm, and pseudocyst. So the correct answer here is a mucinous cystic neoplasm, and we will talk about the rest of these. Benign pancreatic lesions to be aware of, so serous cystadenomas, mucinous cystic neoplasms, intraductal papillary mucinous neoplasms or IPMNs, and then solid pseudopapillary tumors. These different lesions have sort of different characteristic patient populations that they present with, and then different malignant potentials. The more classic ones to be aware of, so mucinous cystic neoplasms tend to be in a younger female. They tend to be asymptomatic, but do have a malignant potential. And so if these are identified, they should be resected. And then IPMNs, the malignant potential of these lesions is dependent on their location and their characteristics. So main duct IPMNs are higher malignant potential than branch duct. Something that may come up is a mixed type. So a IPMN that involves both the main and a branch duct should be treated like a main duct. And then branch ducts sometimes have elevated malignant potential if they have certain high-risk characteristics, such as internal calcifications, internal septations, or enlarging size. Something that may come up is the content of these lesions when aspirated. If an advanced endoscopist does an EUS and FNA, sometimes that can help you with the diagnosis. And so for serous cystadenomas, these are going to have a low CEA and low amylase. Mucinous cystic neoplasms are going to have a low amylase but a high CEA, and that's that CEA tells you that it's producing mucin. IPMNs are going to have both high amylase and high CEA. And the amylase in these is because they're a ductal lesion, and so you're going to get amylase communicating with the lesion. And then pseudocysts are going to have high amylase and low CEA. And of course, pseudocysts are sort of different from the rest of these because these are more sequela of acute pancreatitis. Question number 6, a 64-year-old man undergoes an open pancreaticoduodenectomy or a Whipple procedure for a 3.5 centimeter pancreatic ductal adenocarcinoma of the uncinate process of the pancreas. The tumor has no contact with the superior mesenteric vein. Which of the following techniques is most likely to ensure an adequate resection margin? So our options are division of the pancreas to the left of the ligament of Treitz, periadventitial dissection along the superior mesenteric artery, superior mesenteric vein resection and reconstruction, and portal vein resection and reconstruction. So the best answer here is going to be periadventitial dissection along the SMA. Just to go through these other answer choices and why they're incorrect. Division of the pancreas to the left of the ligament of Treitz, not necessarily going to improve resection margin, as the duct is not necessarily the most common place for positive margin. SMV reconstruction, there's no benefit to performing SMV or portal vein resection and reconstruction unless directly involved with the tumor. And so in this patient where you know that there's no contact with the vein, there's no benefit to adding that to the procedure. But the most common place for positive margin is along the SMA. And so the important technical point is a periadventitial dissection along the SMA. To take a step back and look at pancreatic ductal adenocarcinoma, risk factors include smoking, obesity, and diabetes. Indications for upfront surgery versus neoadjuvant therapy. This is an area of controversy. So again, unlikely to ask questions about this unless it's very obvious. So patients who would be good candidates for upfront surgery would be patients with, generally speaking, small tumors with definitely no contact with mesenteric vessels, in patients who are otherwise fit and whose workup demonstrates no evidence of metastatic disease. Patients who are Definitely better candidates for neoadjuvant therapy would be patients that have sort of classically borderline resectable tumors. And so that might include tumors that have contact with the SMV, potentially even contact with the SMA, but there's lots of different classification schemes for what is borderline resectable versus unresectable versus resectable. So again, it's unlikely to get into the weeds on this because there's so much variety in clinical practice, but in general, contact with vessels is going to make you think borderline resectable, maybe a better candidate for neoadjuvant therapy. Common complications of Whipple's, some of the more common ones would include delayed gastric emptying. That's sort of classically taught as the most common complication. And then the other one to be aware of course, is a pancreatic leak. Not all pancreatic leaks are clinically significant. Sometimes they're detected by checking a drain amylase. And often when detected, it'll be just that lab value would be abnormal, but there will be no sequela for the patient. Just things to be aware of. And then adjuvant therapy is very important for most of these patients. And generally speaking, will involve adjuvant chemo. Pancreatic cancer, of course, is a huge topic and very difficult to cover everything within the short review section, but I think that hits most of the high points. We'll move on. 38-year-old with a history of a fourth gland exploration for primary hyperparathyroidism presents with mid-epigastric pain. Axial imaging demonstrates a periampullary mass. Which of the following is the most likely functional tumor in this patient? So our options are insulinoma, gastronoma, glucagonoma, somatostatinoma, and VIPoma. So the best answer here is gastronoma. Sort of as Dr. Quinn talked about, in patients who you're suspicious for MEN syndromes, specifically if you are suspicious for MEN1, the pancreatic tumor to look for would be gastronoma. For pancreatic neuroendocrine tumors in general, non-functional tumors are by far the most common, even in inherited cancer syndromes. But then the other ones do tend to come up on tests because of their classic clinical presentations. So insulinoma will present with Whipple's triad, which is hypoglycemia, symptoms of hypoglycemia, and then improvement in symptoms with glucose administration. These are more often, sorry, blanking there for a second, more often benign and can be enucleated. Glucagonoma, the important association to think about is the skin rash that goes along with this, which is necrolytic migratory erythema. And that will often show up as a picture question. Gastronoma we discussed, and we'll talk about the location of those in just a second. Somatostatinoma, classically will have the, will present with, gallstones and diabetes. And then VIPomas, classically the most common symptom will be a watery diarrhea or secretory diarrhea. The gastronoma triangle is something that comes up sometimes. So where this becomes relevant is if you do your localization studies to try to identify the location of a gastronoma and it does not localize, occasionally the next best step is to proceed to the operating room and physically look for a tumor in this location. And so the borders of this gastronoma triangle are going to be the common bile duct, the lateral wall of the duodenum, and then the neck of the pancreas. So in that area is going to be where your gastronomas are more commonly found. Question number 8. 47-year-old man with history of multiple bouts of acute pancreatitis secondary to alcohol abuse is referred by an advanced endoscopist who has exhausted treatment options for a proximal pancreatic duct stone with distal dilation. The patient complains of chronic abdominal pain and is interested in surgical intervention. Which of the following would be the most appropriate option? So the best answer here is going to be a Pheochromocytoma procedure. So just to review what our surgical options are for chronic pancreatitis. Sorry, we'll do that in just a second. More common sequela of chronic pancreatitis could be pseudocyst, which can grow to be quite large and symptomatic. Treatment for these is either endoscopic or operative cyst gastrostomy for patients who are symptomatic. Duct stones and strictures are where pancreatic surgeons tend to get involved for these procedures that we're going to discuss here in a second. And those are really a result of chronic inflammation. The chronic inflammation itself contributes to the chronic pain that most of these patients have, which is why splenectomy is one of the surgical treatment options for chronic pancreatitis, because really what we're trying to fix is not the inflammation itself, but the pain that goes along with that. In terms of surgical treatment options for certain sequela of chronic pancreatitis, we talked about cyst gastrostomy. The other ones to know are the Pheochromocytoma, the Beger, the Frey, and then formal pancreatic resections, which can be an option. So the first one listed there is a standard Whipple procedure, not necessarily commonly done specifically for chronic pancreatitis. But then the more common procedures to be aware of. So the Pheochromocytoma procedure on screen right is best done for patients who have a proximal duct obstruction with a distal duct dilation. What you're trying to do is decompress that distal pancreatic duct. And so the operation is really a longitudinal Roux-en-Y pancreaticojejunostomy. So sewing a roux limb of jejunum to the pancreatic duct. A Beger procedure is primarily a resectional procedure, which primarily is going to involve coring out the pancreatic head, as long as that area of inflammation that you're trying to address does not involve the duct. And then a Frey procedure is sort of a hybrid where you're doing a pancreatic head resection with a pancreaticojejunostomy. Question number 9, almost there. A 45-year-old woman undergoes a laparoscopic sleeve gastrectomy for morbid obesity. She returns to clinic for routine postoperative evaluation and is tolerating liquids and has lost 10 pounds in the last 14 days. Review of final pathology shows a 5.2 centimeter gastrointestinal stromal tumor or GIST in the greater curve with 9 mitoses per high power field. What is the next best step in management? So options are observation, advance, or diet. CT chest, abdomen, pelvis with IV and PO contrast, PET CT, imatinib, and cytotoxic chemotherapy. So the best answer is imatinib, otherwise known as Gleevec, which is the brand name. So for patients with a GIST, this is essentially a sarcoma of the GI tract. The most common site for these is the stomach. The prognosis is heavily dependent on the site, but also the mitotic rate and the size. And those key numbers to know there are a size greater than 5 centimeters and greater than 5 mitoses per high power field. Either of those is going to be an indication for adjuvant imatinib. The hallmark mutation is a c-KIT mutation, which may show up as a CD117. Those are the same. The surgical treatment for these is resection to negative margins. So you don't have to get a certain margin on either side. And so if this is diagnosed endoscopically or otherwise, and you're proceeding to the operating room specifically for resection of a GIST, typically a wedge resection, if anatomically feasible, is going to be adequate. Finally, question 10, a 51-year-old man presents with vague abdominal pain and weight loss. EGD reveals a fungating mass that is 3 centimeters proximal to the incisura. Which of the following is an indication for a distal gastrectomy? So options there are Linitis plastica, a CDH1 mutation, a Lynch-associated gastric cancer, intestinal type tumor in the antrum of the stomach, or a broad-based ulcer near the GE junction. And by elimination, we can say the intestinal type tumor in the antrum would be potentially an indication for distal gastrectomy. The other answer choices would not be good candidates for this. The first three of which are because there is risk for diffuse type gastric cancer or multiple gastric cancers. So Linitis plastica is already a diffuse cancer involving the entire stomach. CDH1 mutation is associated with the diffuse type gastric cancer, which leads to a loss of E-cadherin, which is a cellular adhesion molecule, which is why these lead to diffuse type cancers. The important association there is with lobular breast cancer. So they may give you, for example, a woman with a history of lobular breast cancer who then presents for follow-up, and important to know is that that patient needs at least very close surveillance for gastric cancer. And sometimes these patients, if they're diagnosed young enough, maybe even candidates for prophylactic gastrectomy. Lynch-associated gastric cancers, again, those can be multiple and tend to be more aggressive. And then a proximal gastric cancer, proximal gastrectomy might be an option, but might be a risky answer on a test. In general, proximal gastric cancers, the answer is for surgery is going to be a total gastrectomy. For gastric cancer in general, more common risk factors include smoking, and then nitrosamines, which are a dietary component often seen in smoked fish and other smoked foods. The intestinal type is more common and has a better prognosis. And then the diffuse type we just talked about. Upfront surgery versus neoadjuvant therapy can be challenging, but often these patients are going to be good candidates for neoadjuvant therapy. And then the extensive lymphadenectomy, we talk about D1 versus D2 resection, that talks about which lymph node stations need to be resected. In general, in the US, the answer is a D1 lymphadenectomy is adequate, although in practice, many surgeons do colloquially called a D1 plus or even a D2. In East Asia, the answer is a D2 lymphadenectomy, but the etiology and behavior of cancers in that patient population tends to be a little bit different. I wouldn't necessarily spend a whole lot of time memorizing all of these lymph node stations, but the important thing to know is a D1 lymphadenectomy is essentially all of the perigastric lymph nodes. D2 is going to involve the other vessels off of the celiac, so the splenic and common hepatic and that sort of thing. And that's all I have.
Wonderful. Thank you so much, Dr. Chick. And if there are any questions, please feel free to put them in the chat or the Q&A. And last up, we have Dr. Starr.
Hey, just get this started here. So we've got quite a bit of room to cover here for all of cardiac, thoracic, and vascular, but we're going to get through things as quickly as we can. We'll start with this first question. A 47-year-old healthy male presents with 6 months of progressive dysphagia, reports episodes where he regurgitates foods and sensations that things are getting stuck, has had minimal weight loss, denies any heartburn symptoms, upper GI imaging is shown here. So what is the most important diagnostic test to confirm this diagnosis that we just saw? In this case, it's going to be esophageal manometry. This is the presentation for achalasia. Presentation dysphagia of solids and or liquids about 90% of the time for solids, regurgitation 75% of the time, and substernal pain and even heartburn 50% of the time. That's usually due to things sitting in the esophagus and causing direct irritation. In terms of diagnostics for this, chest x-ray may or may not show wide mediastinum. That's pretty rare. The upper GI is going to be kind of the go-to here, that bird beak's appearance. and the dilated esophagus, that is what is going to give it away and kind of clue you in that this is likely achalasia. We do often do EGDs. It shows retained food or dilated esophagus and that kind of characteristic pop at the GE junction. Mostly, though, this is to rule out malignancy as a source of this. But the gold standard for diagnosing achalasia is actually manometry. This must be performed to diagnose achalasia. In that classic type 1, we see these three findings, including the increased lower esophageal sphincter pressure is greater than 45 millimeters of mercury, aperistalsis of the distal 2/3 of the esophagus, and decreased relaxation of the lower esophageal sphincter. Some places say anything greater than 8 millimeters is good. Pseudoachalasia can kind of throw this off a little bit, but in pseudoachalasia, there is a malignancy that implicates the findings that you see on manometry there. In terms of treatment, several treatment options. These will all come up a little bit on the exam. Nitrates are the first line, so oral medications. These often fail most frequently. Most practitioners don't even start with that unless they're extremely high-risk patients. Botox injections to the lower esophageal sphincter. These do fail about half the time within a year. Pneumatic dilation of the lower esophageal sphincter, about a third of those fail within 5 years. And then the gold standard is surgical myotomy, either a Heller with a door or toupee, depending on how you like to do it, if there are other indications for the anti-reflux procedure. And then POEM, kind of a newer preference for some, especially in type 3, where it's a longer need for a myotomy. This may actually be the first line therapy. Here you can see a little bit of the surgical idea with the Heller mostly performed through the abdomen. Now you're going to split the muscle and then perform a partial wrap over the top. Very key here, this will be a partial wrap, not a full wrap. These patients have dysphagia and aperistalsis of the distal esophagus, so we don't want to do a full wrap. And then here you can see the premise behind POEM. If you've never seen this, the whole idea is you're doing a submucosal dissection with an endoscope and actually performing a myotomy of those muscle fibers and then closing the mucosal layer. Second question, you have an 84-year-old who presents with an 8-month history of a worsening oropharyngeal dysphagia, reports of development of halitosis despite having what she recalls as good oral hygiene. She does wake up at night on occasion coughing and says she's had about a 10-pound weight loss. And a barium swallow is shown here. So which of the following muscles is primarily responsible for the development of this finding? In this case, that's going to be the cricopharyngeus muscle. And so this is the presentation of a typical Zinker's diverticulum. These are usually elderly folks, usually in their 7th, 8th decades of life. Men tend to be much more prominent than women in this. They'll usually present with a progressive dysphagia, halitosis, what they report is kind of gurgling in the throat or regurgitation, and then an occasional neck mass, depending on how big this can actually get. The key here is this does result from a weakness at Killian's triangle, which is an anatomical triangle created by the thyropharyngeus muscles and the cricopharyngeus. There you can see some anatomic landmarks in the imaging. So more importantly, what is the classification of a diverticulum that is a Zinker's diverticulum? So in this case, Zinker's would classify as an upper esophageal false diverticula. We'll talk a little bit about the differences in different esophageal diverticula. So it comes in really two flavors, true versus false. So true is a diverticulum that contains all the layers, including the muscle layer. And then false is a diverticulum that contains only the mucosa and or the submucosa. And they come about in two very different fashions. So true versus false is also kind of looked at as difference in traction versus pulsion. So traction diverticula are the true diverticula. Those are often mid-esophageal. We can see that with big lymphadenopathy, saw historically with tuberculosis, where there would be inflammation, and as that resolved, it would pull the esophagus, but it would pull from the outside, so all the layers created that diverticulum. Then pulsion are what we tend to think of as diverticula in the esophagus. These are the ones that are pushed. So the proximal are the Zinker's. That is probably the the most common proximal esophageal pulsion diverticula, and then the distals are the epiphrenic diverticula. And these are caused by a distal obstruction. So if you imagine you're pressurizing the esophagus proximal to this, and there's an obstruction distal, and then you have outpouching of the mucosa and submucosa through the muscle layers. So for Zinkers, as far as diagnostics, it's really usually pretty straightforward on a barium swallow and history. You can really accurately make this diagnosis fairly quickly. You can do an EGD to rule out malignancy if there's concern for that, but it's often unnecessary. When we look at treating Zinkers, it really kind of comes down to a few different options, mostly based on size. So less than 1 centimeter, we do not treat these unless they become significantly symptomatic for the patient, but most of the time at that size, they're not. Surgical diverticulectomy versus a leaving the diverticula in place, but pexing it up to the spinal fascia. But most importantly, either one of those routes, you have to perform a cricopharyngeal myotomy. That is the key to this operation. You have to relieve the distal obstruction, or you're never going to fix the problem with the diverticula. There are newer approaches with rigid endoscopic stapler diverticulectomy. This is essentially like we think about putting a GIA stapler or endo-GIA stapler down the throat, putting half into the true lumen of the esophagus, half into the diverticula, and firing. That creates one common channel, but also divides the cricopharyngeal muscle. And then there are some newer flexible endoscopic techniques that probably won't be mentioned on the exam. Here are some things that you will see that talk about Zinkers on occasion. I will point out the top picture you see there is actually incorrect. That is a bad diagram. You should not do that. There they actually don't show dividing the cricopharyngeus muscle. So while they have done the diverticulectomy, that is an operation that is doomed to failure. There you can see in the bottom left, they're doing a diverticulectomy with the GIA, or actually that's a TA stapler there. But then they've also performed the myotomy, which will prevent that from occurring. And you can see a couple examples of the rigid endoscopic approach using the endo-GIA stapler, and then the flexible endoscopic approaches over to the right. Next is a tall 26-year-old male who presents with acute onset right chest pain starting late yesterday. Claims he experienced some progressively worsening shortness of breath. He denies smoking. He works as an airline pilot for a living, and a chest x-ray is obtained in the emergency department and is shown. The first question regarding this patient is, what is the next best step in his management? Is that oxygen therapy and observation, a percutaneous small bore thoracostomy tube, an open large bore thoracostomy tube, a video-assisted thoracoscopic surgery, or an open thoracotomy? So for this gentleman, the next best step for him would be a percutaneous small bore thoracostomy tube. And so you place that. A small bore chest tube is placed and the lung is re-expanded on imaging. He is admitted and he has an ongoing air leak after placement, which ultimately prompted a CT scan to be performed, which demonstrates the following findings. So he gets admitted, he continues on suction. He has an air leak that persists for the next 48 hours despite this treatment. And at this point, the question becomes, what is the next best step in the treatment of this patient? Is that convert him to water seal despite his ongoing air leak, continue suction for another 24 hours, proceeds with a VATS with a mechanical fluoridesis, proceed with a VATS with a wedge resection and chemical fluoridesis, or proceed with a VATS with a wedge resection and mechanical fluoridesis? And for this gentleman, I would recommend early intervention with a VATS with wedge resection and mechanical fluoridesis. So this is the presentation for a typical spontaneous pneumothorax. Men way more often than women to come in with this, up to 6 times higher in men. Smoking is one significant risk factor. So smoking alone, up to 102 times higher if you smoke a pack a day or more. And that's the wrong symbol there. Greater than 50% of patients present with what we call, quote, mild collapse. So just minimal symptoms. They may have some chest pain and shortness of breath, but it's nothing hemodynamically or respiratory significant. Diagnostics, really chest x-ray is the definitive imaging. That's really all you need. Potentially you find these on patients who come in with a little bit of chest pain. They have an occult pneumothorax, so it's not seen on chest x-ray, so you may get a CAT scan that shows a very small pneumothorax. However, if that's the case, they're often too small to even treat other than oxygen therapy alone. The big advantage of CT scans is you can identify potential sources of pneumothorax etiology, such as in this patient there. For treatment of these, it really kind of depends on what you have, and it's really based on size at the very beginning of this. So very small to small, oxygen therapy and observation alone is really all you need. Sometimes these will resolve spontaneously. The whole idea is that oxygen will be diffused into the blood and up into the tissue faster than our air, which is composed of mostly nitrogen and can linger around for a while. So if you can have super oxygen atmosphere within that air that is being leaked into the thorax, you will be able to resolve that pneumothorax spontaneously. Moderate or greater really do require a thoracostomy tube. The debate comes to whether you really need a true open large bore tube or whether you can do it with a small bore tube. I think for most of us, a small bore tube has become the first line approach for pneumothoraces. And then continuous suction. So you want to monitor for air leak for at least a couple days. And then definitive treatment for this really depends on their presentation. So if this is their first episode and the air leak resolves, then you send those patients to water still and you pull the tube in a few days. However, if they have a persistent air leak, you continue suction for up to 5 days. Studies say you can go as early as 3 days, some as late as 7 days. But if it continues, you want to proceed with VATS for an assessment of the etiology and treatment with pleurodesis. If this is a second episode, or they have significant risk factors that you can see down there, say they're an airline pilot, say they're a scuba diver, say they have hemodynamic compromise at their first event, then you would want to proceed early with an operation for potential definitive management. So someone asked why mechanical pleurodesis and not chemical pleurodesis. Mechanical pleurodesis actually has a slight benefit, but probably one of the biggest benefits to that is chemical pleurodesis is often quite painful. The agents used for that now is talc. Talc is really reserved for those patients who have cancer. It can be malignancy inducing, so that's usually used for folks who have malignant pleural effusion. But the other chemical agents tend to be quite painful to tolerate. Doxycycline, erythromycin has been suggested that those cause significant pain to the patient. So typically, you would go for VATS and do a mechanical pleurodesis at that time. So the next patient is a 68-year-old who presents with tearing chest pain that radiates to his back. In the ED, his blood pressure is measured at 192/107, and his heart rate is 83. He has a history of hypertension, diabetes, hyperlipidemia, and smokes 1 pack a day for the last 50 years. He has a CT performed which demonstrates the following findings. So what is the first step in the management of this patient? Admit for observation, beta blocker infusion, nitroglycerin infusion, heparin infusion, or palliative care consultation. So for him, the first line of therapy would be beta blocker infusion. And then what is the proper classification for these findings that were seen on CAT scans? So ascending aortic aneurysm, an acute Stanford type A dissection, an acute Stanford type B dissection, or an acute DeBakey type 3 dissection. So in his situation, this is most likely, based on the imaging we saw there, is in the Stanford type A dissection. And then the last question for this one, which of his findings put him at the highest risk for development of this disease process? Diabetes, uncontrolled hypertension, cigarette smoking, or hyperlipidemia? In his situation, the uncontrolled hypertension is going to by far be his biggest risk factor. So this is the case of an aortic dissection. The presentation usually on acute onset tearing chest or back pain, occasional stroke symptoms if this does progress up through the carotids and into the head vessels. Occasionally this is hypotension. If they rupture, that can lead to tamponade. And then occasional systemic malperfusion if that dissection proceeds around the arch and down through the visceral block. Risk factors here, hypertension by and far the largest. It's often a complication of known aneurysms, so genetic diseases that predispose you to soft connective tissue disorders, Marfan-Lowe's, Ehlers-Danlos, that lead to aneurysm disease also predispose you to dissection of that aneurysm. Smoking is a risk factor for aneurysm disease, which can lead to dissection, but it's kind of an indirect mechanism. And bicuspid aortic valves, we know that they have an underlying aortopathy, which also predisposes them for dissection. These dissections really come in two flavors: the Stanford type A, tear at the origin, tear before the origin of the left subclavian. These are what are known as the ascending dissections, or Stanford type B, that tear after the origin of the left subclavian. These are the descending dissections. And your type really determines your treatment here. For type A, this is a true surgical emergency. Mortality in these patients is significant without treatment. Greater than 50% will die within the first 24 hours, and up to 75% within the first 48 hours if those aren't treated. These patients will oftentimes dissect down the coronaries, their valves become incompetent, and they can get pretty rapid heart failure from this if not treated. Biggest answer with any of these is to begin with anti-impulse therapy. You want to reduce the shear force, reduce the blood pressure with beta blockade for a heart rate less than 60 and systolic blood pressure less than 120. This is one of those situations where you've got to get cardiovascular surgery immediately on diagnosis for definitive. There you can see an ascending hemiarch repair on the right with valve resuspension. And then type B. These are more vascular approaches. So in these repairs, it's typically endovascular stenting now. This is kind of the gold standard for this, and it's TVAR. Increased length of these TVARs does put you at risk for spinal ischemia. Think about the artery of the Dankowitz. So the longer you make these stent grafts, the more risk you have of creating ischemia within the spinal cord. An open approach for these is often unnecessary. Typically, these do not get treated surgically unless there is evidence of malperfusion of the distal organ or there is evidence of rupture. Most of the time, these can be treated manically without any sort of procedures. The other option is distal fenestration. So the idea here is if you go in and you create a place distal for the true lumen to recharge, then that segment where the dissection is will recharge the distal segment and improve blood flow to the visceral block. So you don't have evidence of renal malperfusion or gut malperfusion. Then there is a picture again of the vasculature that leads off of the aorta directly to the spinal cord, and if you cover that up with a covered T-bar graft, why you can end up with this. This is the idea with distal fenestration. There you can see the true lumen is kind of recharged by opening up a hole there, and some people even place a little stitch so that it has to be recharged. Next is the 72-year-old man who presents with right upper quadrant pain and tenderness. His white count is 17, and a right upper quadrant ultrasound demonstrates acute cholecystitis. He had a heart attack with PCI 2 months ago with drug-eluting stents. He's on ticagrelor and aspirin. How should you proceed with treating his cholecystitis? Immediate cholecystectomy, hold his aspirin and Brilinta, and oath to the OR in 7 days. Antibiotics and observation, cholecystostomy tube placement. So for this gentleman, I would recommend kind of the step-up approach and start with antibiotics and observation. We'll talk about that. And when is the earliest it is safe to discontinue dual antiplatelet therapy for elective or semi-elective non-cardiac surgery after the use of drug-eluting stents? As soon as the need arises, 1 month, 6 months, or 12 months. And so for this answer, I put 1 month, and we'll talk about why that's changed a little bit. A very safe answer here is 6 months, and the ABSITE may still be going with 6 months, but we'll talk about why that's changed a little bit. Dual antiplatelet therapy is kind of the mainstay of treatment to prevent stent thrombosis following PCI. So dual antiplatelet consists of aspirin, 81 milligrams, plus one of the other agents seen here, Plavix, Brilinta, or Effient. This must be continued following the placement of stents prior to the reendothelialization, and that's why it's important to understand the difference in the bare metal stents and the drug-eluting stents. Drug-eluting stents elute actually a cancer medication so that you do not have reendothelialization to prevent recurrence of in-stent disease. So they try to delay that as long as possible to reduce inflammation. The question here is, when is it safe to stop for non-cardiac surgery? So the guidelines for this are constantly changing. And here's kind of the rundown as it currently stands. The safe answer for your ABSITE is probably drug-eluting stents, wait as long as possible, but at least 3 to 6 months. For bare metal stents, wait as long as possible, but at least 1 month. However, newer recommendations have come out in the last few months to say if it's a non-emergency surgery, whether it's bare metal stents or drug-eluting, it's safe to stop at 6 months. If it's time-sensitive surgery, so even some cancer operations that they say need to be done very, very soon, you can stop at the 1 month, but they would prefer up to 3. This is all a risk-benefit conversation, is what the patient's risk for a thrombosis is. The question is how long do you need to stop them before surgery? So for Plavix and Brilinta, it's 5 days. For the Effient, the Prasugrel, it's 7 days. And then you want to restart those as soon as it's safe from a bleeding standpoint based on the surgeon's experience. A couple more questions we'll kind of get through quickly. So a 61-year-old presents to your office for evaluation after PCP visit for some slurred speech and right-sided weakness a few weeks ago. All of the symptoms resolved fairly quickly. His PCP heard a left-sided bruit. What is the next best step in evaluation of this patient? Observation, carotid Dopplers, CTA of the neck and chest, a brain MRI, or carotid digital subtraction angiography. So for him, it would be a carotid Doppler exam as initial screening. And then he underwent a carotid Doppler, which showed velocities consistent with a right ICA lesion of 50 to 69% and a left ICA lesion of 80 to 99%. He's otherwise healthy. What is his treatment of choice? Strict medical management, left carotid stenting, left carotid endarterectomy, or bilateral carotid endarterectomy. So for him, would be recommended for a left carotid endarterectomy. So most of the time, these patients present with neurological symptoms, mostly TIAs, syncope, strokes, occasionally with dense neurologic findings. You'll occasionally hear a Brouillon exam, and the patients are asymptomatic. Screening tests now find otherwise asymptomatic disease, carotid Dopplers in patients for other reasons, known atherosclerotic disease will find this. Risk factors are the same as for all atherosclerotic disease: hyperlipidemia, smoking, hypertension, and diabetes. The diagnostics, the Brouillon exam, angiography, digital subtraction angiography is still the gold standard, but it's invasive and it's often deferred for other non-invasive studies. Carotid Doppler studies, this looks at the velocity. Now, these velocities are lab dependent. Each independent lab will have a different range that gives an estimate of the stenoses. So that is important to know. It's really hard to go off of one number for these. CTA and MRA are good, but they will often overestimate the degree of stenosis, but they do give you good anatomy planning for pre-surgical evaluation. So for treatment, there's a couple studies, the NASA and the ACAS trials. It really depends on whether you're symptomatic or asymptomatic, what your life expectancy is, what your symptom timing is, and then other risk factors. Have you had radiation? Is it a redo? Are there other surgical risk factors like coronary disease to put you to sleep? No matter what, all patients get risk factor reduction, antihypertensive regimens, aspirin, statin, diabetes management, and smoking cessation. Here's the lowdown. If they're symptomatic, treat patients with greater than 50% stenosis if you think they have 3 years of life expectancy. Treat patients with 70% stenosis or more if they have 2 years life expectancy. Asymptomatic patients are different. Less than 70% medical management. Greater than 70%, if you think they will live for 5 years, then treat those patients. Some surgeons will wait up to 80%. It just depends on how aggressive you want to be. When should you do it? Sooner actually better than waiting. Most recommend now within 2 weeks, unless you had a large ischemic stroke. But typically by that time, your risk of conversion to a hemorrhagic stroke are pretty low. You do want to await a plateau in their symptom resolution. So if they had a dense stroke, you want to get them through at least the early portion of their recovery before you put them through a surgery. If you have a total occlusion, do not operate, leave those alone. If you have vertebral disease, do not operate, leave that alone. 2 pearls for endarterectomy. Just remember the hypoglossal nerve is in play proximally. I'll come back to that question about why wouldn't you do bilaterals. Heparinize the patient. This is probably the most important thing. You want to clamp your internal first, followed by the common, then the external. That way you protect the internal from any debris that may go up that way when you clamp the common. You decide then whether you're going to shunt or not to shunt. You remove the plaque, you do a patch closure, and then you unclamp in the opposite direction. You open the external first, you open the common, so you flush any debris out into the external, and then you open in the internal to reestablish flow. This patient was symptomatic, but the symptoms were a single side. So you would want to treat the severe side in this guy before you would treat the other. And certainly 50% without symptoms coming from that side, you would just leave that alone and treat medically. And then the last patient, we'll get through this pretty quickly. 52-year-old lady with atrial fibrillation presents with 4 hours of worsening right lower extremity pain. She claims her foot feels cold and has been getting more numb over the last few hours. On exam, she has no palpable pulses or Doppler signals in the right and normal left-sided exam. Her femoral pulses are palpable. She has weakness in ankle flexion. What is the best treatment for her definitively? A heparin infusion, ECOS catheter for DVT, angiography and stenting, SEM-POP bypass, or surgical thromboembolectomy. For her, this would be a thromboembolectomy. Surgical exploration, you remove clot via Fogarty catheter and good inflow is confirmed. She regains palpable pulses in the foot. Her lower extremity becomes hyperemic. What is the best step to prevent further ischemia complications? A thrombolysis infusion, ACE-RAP to the leg, perform a bypass procedure, fasciotomy, or amputation. So for her, fasciotomy would be indicated based on how long she had been having symptoms. So presentation for this, usually sudden onset, pain, decreased sensation, decreased motor function, loss of pulses. Causes, again, lots of reasons here: atherosclerosis, progression of disease, thrombosis, dissection, like we talked about earlier, aneurysm, thrombosis, injury or trauma, and embolic events such as AFib or a plaque that ruptures and then thrombosis off. You can see this with vasoconstriction if they're on vasopressors or things like that. And then venous obstruction can actually lead to arterial inflow problems, a process known as phlegmasia. The Rutherford class really kind of drives what we do. So you can see it's class 1 through 3. It tells you, are they having sensory impairment, motor impairment, and then what the Doppler signal exam would look like. And it classifies them whether there's immediate threat, marginal threatened, immediately threatened, or irreversible ischemia. And then that determines how you approach that, whether it's straight to amputation or attempts at revascularization for monitoring. Treatment for this, you always initiate with heparin to prevent propagation of clots. Thrombolysis, not a great option in most acute patients with threatened limbs. It just doesn't tend to work all that great in most patients. Surgical embolectomy is probably what the go-to is for most patients, but it often depends on what the nature. 2A or 2B often needs revascularization, which would be thrombectomy in this case, or some sort of bypass. If it's stage 3, they likely need an amputation. Often a thromboembolectomy will reinitiate inflow and outflow. If it is acute on chronic disease, you may need to consider definitive bypass, whether that's SEM-POP, SEM-FEM, or something like that. And then further management, you have to treat their inciting events. So they would be on anticoagulation for a period of time. Peripheral arterial disease risk factor management, like we talked about earlier, same as kind of for stroke risk factor management. And then you've got to prevent the secondary injury at the time of this acute presentation. So typically at over 4 to 6 hours, you would consider a prophylactic fasciotomy. We would defer to a 4 compartment to get the superficial posterior, the deep posterior, the anterior, and the lateral compartments, usually a 2 incision approach for this, a medial incision, a lateral incision. And then you monitor for rethrombosis due to endothelial damage at the site where that spot got lodged. A lot of information in a short period of time. Any further questions? I think I saw most of the questions in the chat. When you do chemical pleurodesis, you use talc for malignant? Yes. The doxycycline for non-malignant is an option, but quite frankly, most people will do a mechanical pleurodesis. You know, if you're going to do it, something like doxycycline or erythromycin, anything that you can put in there to produce an inflammatory response. The problem with that is it is pretty painful. And then we talked about why would you do bilateral carotids in that patient presented there.
Wonderful. Well, thank you so much, Dr. Starr, and thank you everybody for participating in the webinar today. This is a very educational panel. We cannot thank Dr. Quinn, Dr. Chick, and Dr. Starr enough for putting together these great slides. And a big thank you to Paige, Amy, and LK for making this webinar possible and keeping us all in line. And thank you to Maria, who founded the webinar series. And definitely thank you to Dr. Fong, who has helped teach me everything I need to know to help moderate, which thank you. I don't know that there will be a PDF file, but there will be a YouTube video that's uploaded that will have all the slides. And you can find that on the SSAT website, and there's also a YouTube channel that we have. So thank you all so much. Have a wonderful night.